I would like to open the floor to questions and ask if the speakers might come up closer to the microphones. Any questions for any of the speakers? James, while I'm at it, I think your idea was personalized medicine, right? To kind of use this idea to predict who might respond. Do you think that you can use this molecular modeling to identify new treatments? So identify a node at the intersection of two, and maybe even get a more potent treatment though.
So that's an excellent question, and it's actually something that we've been doing in cancer research. So the precedent is set that we can actually use master regulators to predict and develop drugs. So in cancer, we use it to identify specific modalities in tumors that they might be dependent on. So if you identify 4 master regulators, you now want to develop drugs that specifically target those master regulators, so then you can diagnose patients with based on the master regulators and then match them directly to that drug. Mm-hmm. So we are actively doing that in cancer.
Great. Jerry, do you want to start?
I will. Thank you. Enjoyed this session very much. I treat a lot of patients with cyclosporin for alopecia areata and do so quite successfully. The problem is once they respond, how do I get them off the drug? And I got various recipes I use. Had never thought about using tofacitinib. And so the question I have of anyone who wants to respond on the panel, is there any experience out there using tofacitinib as a way to reduce cyclosporin dosage for treatment of diseases like alopecia areata or vitiligo?
I'll take that one, and I'll say that at this moment I don't know of anyone reporting use of tofacitinib as a dose-sparing agent for cyclosporin. I would argue that at least so far the results of using just tofacitinib as opposed to cyclosporin would suggest that you might be better off with the tofacitinib. But I do think you raise a very important point, which is that with all treatments of alopecia areata, at least to date, they're not cures. And we do have to figure out how to get people off of some of these strong drugs, but yet maintain their hair loss. And I think that's where the idea of topical drugs might be something that might be very helpful for us. But certainly a lot of work needs to be done on that. And I'm not aware of any with vitiligo. Do you?
Yes, cyclosporin hasn't done a whole lot for vitiligo, but the question, if you start to combine drugs, can you reduce the dose of each one or get synergistic effects? You totally could. The concern is always about overlapping toxicities too, and I'm afraid of cyclosporin. For a disease that most people don't use systemic therapies for, in moderating the kidneys, and knowing that I can only get them on it for 6 months and then I have to take them off. I'll use it in extreme circumstances, but not that often.
So I could just add a little bit to that. So originally when we were thinking about transplant, so cyclosporin, which blocks the TCR pathway, and JAK inhibitors, which block the cytokine pathways, we showed preclinically, if you put these two together, both at completely ineffective doses, you get incredible synergy in a very rigorous heart transplant model. So I'd be really surprised if you couldn't dose people with low doses of both of these drugs and see minimal tox and really, really nice efficacy.
And just to defend myself a bit, I suppose I'm a bit of a cowboy, but the other choice that I see for vitiligo and especially for alopecia areata is steroids. And if you want to change somebody's life, put them on a dose that's responsive, where you can get alopecia areata to respond. And you then quickly realize that there's a better drug out there. And it's cyclosporin for a shorter period of time.
Great. Sam?
Hi. I'm fascinated by your observations about incident light stimulating the cells to repigment. But you showed the cytokine sort of repair after treatment. But have you actually gone back and did biopsies on the skin to see if the melanocytes are there using immunohistochemical staining techniques?
No. So this is hot off the presses. We just submitted this paper recently, and it looks like it's provisionally accepted. So I threw all this in this morning. This is really hot off the presses. And this is primarily an observation that Brett King made. And so he sent the patient to us, to Blister, to try to get in the skin and see what was happening. Because, if you need light therapy plus drug, the question is it drug plus light to suppress the immune response to a point where you need to, where you get repigmentation, or is it that the drug suppresses the immune system and you need a little tweak of the melanocyte by light to get it back? And so that's what we were trying to address here. And it looks like tofacitinib was very, very good at shutting off the entire immune response in the skin. And so we're concluding that you really need a little bit of light to tweak the melanocyte. But I don't want to, I can't emphasize enough that this was not phototherapy. It's not that you need tofacitinib plus phototherapy. It's that we don't know if it's room light, visible light, if it's, it's certainly not a therapeutic dose of UVB that's required.
Yeah.
So the question is, yes, can we dig deeper? Can we get in a little bit further and actually see the melanocytes repigmenting? The challenge there, though, is remember, when you see pigment in the skin from repigmentation, the melanocyte got there probably a month ago. Because the epidermis has to turn over, and the transfer has to differentiate, transfer the melanin to the keratinocytes. They take it up. So it's a very challenging process to try to hit it right at the right time.
Yeah. Oh, good. Yeah. Did he didn't try shining incident light on some of the people who had protective covering just to see if they would respond?
One patient used UVB home phototherapy and responded everywhere. And everybody else responded only where the clothing wasn't covering the skin.
Okay. All right. Thanks.
Yeah. Anthony?
Yeah, thanks very much for the great session. Question I had was for the group was mechanistically it's clear that the JAK inhibitors can be very useful for inflammatory diseases, but there's also this broadening more of a larger market for non-inflammatory conditions like androgenic alopecia, which was mentioned in the talk today. There's suggestions that there's cell autonomous effects in the hair follicle epithelium from K14 knockout animals. So I guess the question would be, what's the sense of and the market for non-inflammatory applications for the JAK inhibitors, in particular for androgenic alopecia? A related question is, the patients that we treat have both alopecia areata and androgenic alopecia. So when you treat those patients, does the androgenic alopecia go away as well, or do you just see the same male pattern baldness effect as the hair regrows?
Great questions. So I'll start with the second one because I actually had a picture in my talk of someone who we treated for alopecia areata. He had totalis, and he had had it for many years, and this was a young guy in his mid-20s. And we treated him, and he had a full response to the higher dose of tofacitinib, but as he regrew his hair, it became clear that he had male pattern hair loss. And so it's a very interesting question. As I mentioned in the slide, it's complicated because the positive results that were seen by Harrell et al. Were with topical use of a JAK inhibitor. And so there may be reasons why topical treatment may be more effective in the pattern hair loss variants versus systemic treatment, but a lot of work needs to be done. As far as the patient interest, I mean, I can tell you when that publication came out in 2015, I can't tell you how many people came to me with pattern hair loss saying, please put me on these JAK inhibitors, and haven't done it yet. But I do think there's definitely huge interest. But I think, especially for patterned hair loss, where you're talking about decades of potential treatment being necessary, I think we need to figure out a little bit better how we can treat these patients long-term safely with these drugs. And again, I think the topical
because
might
I
be the
think
key.
there's if you have a hammer you're looking for a nail, that's one thing. But in terms of overhyping what we can produce or what we can actually treat, and the patients will come in and do anything for us. The question is, and then how do you counsel your patients then in terms of?
I will tell you, for that particular instance, I said, listen, this is exciting stuff. This is wonderful that we are seeing this, but this is in mice. There is so much more work that needs to be done before we would reasonably want to put someone on a JAK inhibitor for patterned hair loss. But it's promising. It gives us hope for another modality of treatment, but there's a lot of work that needs to be done, and that's what I tell the patients. And there are many patients who I would not put them on it because it's too early.
Thanks so much.
Mm-hmm.
And I wonder if hair miniaturization, that's a big difference. So maybe it would be a better preventative treatment, but it might be difficult to reverse that miniaturization of the hair, which was not required in the mouse. It was shaved and then treated, and the hair grew really well.
Yeah. I mean, in theory, maybe use ruxolitinib, not ruxolitinib, sorry, finasteride, not finasteride, I'm talking, minoxidil. There we go. You know, in theory, you could potentially use something like minoxidil to help with some reversal. But, you know, again, so much work to be done, but.
Together.
Yeah, exactly.
Sure.
In the 90s, when we were working with Protopic, I noticed the first patient with vitiligo repigmenting on his scalp, but never on the hands or other areas. Is this same thing? I assume it's a different molecular size, perhaps, but what about with the JAK inhibitors? Do they work on all sites? Do they get through the skin when it's on the hands?
Well, penetration, maybe you guys can answer penetration of the different sites. One thing, though, with Protopic, you're right, Protopic works absolutely great on the face, as does every other treatment we use for vitiligo. The face is covered with vellus hair follicles, and everything allows the face to repigment faster. One thing, though, that I've found is, and others have reported it, is if you occlude the Protopic. So I had a patient who got phototherapy. She had vitiligo. She did incredibly well, except her vitiligo on her shins didn't. And she was using Protopic there for a year. And then I said, why don't you occlude it? Wrap it in saran wrap before you go to bed every night. And she came in 3 months later, and she was completely repigmented. She said, why didn't you tell me this a year ago? And I said, well, you know, it's hard to kind of do that. But that was, occlusion actually, for her, helped a lot. And I don't know if...
Right. I think the molecular weight of most of the JAKs are not bad, under 500 molecular weight. If it's done right with right vehicle and right occlusion, like you said, that can be delivered. Thinking of this palmar kind of surfaces where it's difficult to penetrate, but most other areas you can.
And one other thing, if you think about the speckled vitiligo pattern, is this a mosaic difference, and would two different drugs perhaps work better on some of those?
Speckled pattern. Describe what you mean by that.
Well, there are often little spots of pigment left, and it's very speckled.
Yeah, I mean, there are a number of speckled. There's in one case you can have tiny little macules of depigmentation. It's called confetti depigmentation. Amit Pandya described it last year and showed that when you see this pattern, it's actually very common. You have 1,000 1 millimeter macules of depigmentation all grouped together. That's highly active disease. And when we see that now, we give them actually systemic therapy to treat them. And then another speckled pattern is the perifollicular repigmentation pattern as well, and that's kind of the opposite. That's everything coming back. But the question that I think you were getting to, you know, James alluded to that different people are different. So this one might respond to this one differently than, and you use this drug for this one. I think your question is, do you have, within a single patient, could the right arm respond to one drug and the left arm respond to a different one? And I think I never thought of that, but I think that's an interesting question.
Yeah.
So to
Has
add on to
anyone
that-
looked at genetic mosaicism?
Yeah, so to add on to that, I don't know necessarily about strict genetic mosaicism, but there is literature out there that we're currently exploring that there is heterogeneity in the gene expression profiles of scalp skin relative to skin on your elbow, skin on, and theoretically we have no research that currently supports it, but in theory this could actually affect the response to drugs' molecular mode of action independently of delivery mechanism. So it's kind of a non-answer, but theoretically, yes, it is possible.
It's a question for Keith Choate, if he's here somewhere. Thanks, everybody. If there aren't any more questions or any more comments, I appreciate everybody sticking around and staying for the